Great. Good morning, everyone. I hope everyone had a very lovely weekend and is excited to be back at work and able to hear this presentation about extreme clutter. My name's Laura Katawaki, and I'm a research and knowledge mobilization specialist with United Way BC. I'm really happy that we're going to be able to have a presentation on this topic, as I know this is something that we often hear from agencies about wanting to know more about topics like extreme clutter and hoarding and how they can better support older adults who are dealing with these challenges. So I think this is going to be a really valuable session. Before we begin the webinar, I'd like to start off with a land acknowledgement. So we acknowledge the homelands of the Indigenous peoples of this place we now call Canada and honor the many territorial keepers of the lands on which we work. Today, I'm working from Burnaby, and Burnaby is located on the ancestral and unceded homelands of the Hunkaminam and Squamish-speaking peoples, and we're grateful for the opportunity to be able to work on this shared territory. And I'd encourage you, if you know the lands that you're gathering from, to put a land acknowledgement in the chat if you'd like to introduce yourself. A few housekeeping notes before we begin. So during the webinar, everyone's going to be muted, but feel free to use the chat box if you'd like to introduce yourself. You can put in your name, your pronouns. I use she and her, your organization, or the territories you're calling from, whatever you'd like to share. You can also turn on the automatic closed captioning feature using the CC button at the bottom of your toolbar if you'd like to turn on closed captioning. There is going to be a question period at the end of the presentation, but feel free to put in questions in the Q&A box at any time, and we'll get to those at the end of the presentation. And just want to also note that the webinar is being recorded, and we'll be posting it on Healthy Aging Core, and also we'll be able to share out a PDF of the slides and some other resources at the end of the webinar. So there'll be a follow-up email that will be sent to everyone with that information. And so without further ado, then I'd like to introduce our presenter. So today we are going to be hearing from April Struthers. She's the Director of Knowledge Exchange, Research and Learning for the BC Association of CRNs, or Community Response Networks. She works with the program team on developing content, is a member of the evaluation team, and was a long-term regional mentor. And she's lived on the Sunshine Coast since 1976, so hopefully she's enjoying some good weather. Outside of BCCRN, April works in Canada, the UK, and the US as an organizational consultant, primarily around the prevention of violence and discrimination and anti-racism. And she's written extensively on promising approaches in the field, networks, cross-cultural, and culturally safe work. Recent conference presentations that she's done have included the Canadian Association on Gerontology, the BCCRN Summit, the Network for Relationship Violence, and the Council to Reduce Elder Abuse. And I had the pleasure of hearing her speak there, so know that we've got a great presentation in store. And April has a master's in social psychology and is a registered clinical counselor. So I'd like to welcome April, and she will be presenting now on extreme clutter.
Thank you, Laura. I'm just going to bring up my slides. And let me just say that it's a real pleasure to be with you today, to be able to do this presentation. We know from our experience, and we've heard from Laura and others, that understanding what happens as clutter grows in someone's life and understanding its relationship to hoarding and hoarding disorder is a topic area that people have been interested in for some time and certainly emerges at the community level, no matter what your role is in the community. So it's something that we've been thinking about and have seen through our CRNs. And so we produced this introduction to extreme clutter. And I'd like to say that really this is about awareness and understanding, but that the whole area of hoarding, understanding of hoarding, the treatment of hoarding, and so on is an area where, to date, solutions and definitive supports around the province are lacking in some areas. But the importance of this presentation is to help start the conversations in our communities to develop the support and the resources needed. And just to take a moment to introduce you to the organization that I work for. The BC Association of Community Response Networks is a provincial organization which was piloted in the mid-90s, and it is related to the adult guardianship legislation, where the legislation allows for there to be community supports and a support organization, which is the BC CRN, to work at the local level in developing coordinated community responses. And we do that through our self-organized networks. And so we work on prevention at the primary level, and we provide education, materials, and resources to build awareness and to create conditions where there can be the prevention of abuse, neglect, and self-neglect. And we also get involved provincially, nationally, and internationally on different initiatives, and certainly have worked side by side with United Way and others in the landscape of senior services and prevention of violence. We have a number of key relationships throughout the province, so we are linked to the list of organizations that you see in the box on the left. But we also have somewhere between 92 and 96 CRNs now in about 265 communities in BC. So we have a provincial spread, and we are unique in that we are directed really by what is needed at the community level across the province. So today we're going to talk about clutter, what it is. We're going to hear a couple of stories and then work through the definitions and take a look more deeply at hoarding disorder, which may or may not be operating when clutter is part of the situation. We'll look at the rates of hoarding disorder and the patterns and its relationship also to abuse, because that's an area in which we focus a lot. We'll talk about what the help is that's available at the individual and then at the community level. And it's a complex situation, as you probably know, if you've ever had anything to do with individual cases. And it needs community awareness and community team approaches in order to work with it effectively. And we also offer other resources, which will be coming to you in an email after the presentation. And we have done a fairly deep dive into this issue. So we have 4 pages of scientific references, and then we have a resource guide which directs you to places where there's a lot more in-depth information about this particular topic. But I would like to mention that this material is about, some of it is about mental health conditions, and that information may be traumatic for people or may re-traumatize people or viewers. And so we would ask that if you need to, that you look for support and information, possibly through your local adult mental health resources. So let's begin with a story of a situation and how it develops over time. So we're going to talk about John. John experiences some constraints in his living conditions, really, due to excessive possessions. And John has always acquired possessions, mostly paper and clothing and free giveaways. Up to age 14, his parents, mainly his mother, cleaned up when his possessions started getting in the way of his family space. At 18, John left home, but over time had problems with his landlord and at work with the amount and the disorganization of his possessions and his projects. By the time he was 22, he wouldn't let anyone into his residence. He had trouble with relationships, and at his mother's urging, he went to his doctor and was put on anti-anxiety medication. But over time, the severity of clutter increased, as did John's social isolation. Now, John's mother advocated on his behalf and supported him, and after a length of time and at the age of 35, John was referred for an assessment, and he was diagnosed with hoarding disorder. So that's an individual, but now let's look at a community that begs the question, what do you do in a small, remote, rural, very dependent island community with virtually no services and an emerging clutter problem? So one of our regional BCCRN mentors received a phone call recently. A trailer park and RV site on a remote British Columbia island was managed and owned by compassionate landlords. They contacted a CRN who referred to the mentor because the CRN didn't know what to do about this. The landlords explained that the situation was three longtime residents who they described as having many problems, but as being valued community members. And they were all starting having clutter expanding out of their trailers and their RVs into common space. Now, in this location on this island, there's few services. They have one RCMP officer, a volunteer fire department, who has trouble filling its roster since the mine closed, and they have one half-time resident retired doctor and one community nurse. The mentor asked the landlords to contact home and community care through Vancouver Coastal Health in an adjacent community that's a ferry ride away, so that a limited but coordinated approach could be developed. And this response is just getting underway, really, and the outcome is unknown at this point. Now, generally, we don't think much about our possessions until there's a problem or we need to relocate. There are times, though, that possessions and the spaces where we live become problematic in a chronic way, as is illustrated by these two stories. So let's start this exploration with the definitions of different categories of keeping and managing our possessions. So clutter is defined as a case where possessions are disorganized and may accumulate around living spaces. Clutter occurs for most of us, most often in storage areas, but that is different than living spaces. Collecting is a different situation. That's where there's a number of possessions, but they're part of a larger set of organized items. The display is usually public when there's a collection, and it does not impede the active living areas in a home. In hoarding, possessions become unorganized piles, preventing rooms from being used for their intended purpose, and this is private. There is excessive acquiring, and there is distress with discarding the possessions. Now, squalor is a different situation. It's a description used when there are unsanitary conditions in the home, but not all hoarding behavior results in squalor. And squalor is from passive accumulation of items, but hoarding is defined by active accumulation. Now I'm offering you a picture of my shed as an example of storage space. And this is normal clutter. This is where there's a number of items that might be disorganized within a storage space, but that's where they are. They do not impair your household or the functioning of the shed, actually. And I have the ability to discard with only minor distress and usually with support of my friends to do that. And I only acquire in a non-excessive way. And this does not affect my life. It does not impact my finances or my social life or my relationships. Hoarding, though, is different. It's extreme human behavior, as if there's no off switch, and as if decisions to discard takes enormous energy, and objects have a different meaning and attachment to them is different. And this can lead to excessive clutter. So what you see now are pictures from a scale that professionals use to see where clutter is becoming problematic and where there's a continuum. So the possessions are shown in different rooms of a house, and here in number 1, in a bedroom, there's no sign of clutter. Image 4 shows the amount of clutter, usually where if a professional was to witness this, they would start to get concerned. In image 6, the bedroom is extremely cluttered, and it would be probably gauged moderate to severe. And the ability to use the space as intended, that is, as a bedroom, cannot happen. Now, clutter can arise for other reasons besides hoarding disorder. Circumstances or other physical causes can lead to extreme clutter. It can be due to stroke, traumatic brain injury, or dementia, or exist because of an inability to handle the physical characteristics of clutter, not being able to move or to pick up items, maybe because of being injured or having mobility issues or declining health. In this case, though, accumulation is not purposeful and people can usually discard with some support. And the pattern of other causes besides hoarding disorder is different from that of persons who might be diagnosed with hoarding disorder. This presentation mostly deals with the features of hoarding disorder classed as a mental disorder and its effect on families and on communities. So there are common misconceptions about hoarding as a condition. Most people have only seen those somewhat sensationalized and stereotyped behavior and consequences of extreme clutter, as in the television series on hoarding and hoarders. So blame and stigma are commonly found in how this topic is viewed. And when the term hoarding is used, it's as if it is a character defect rather than a condition of which clutter is a symptom. So exactly what is it? Well, the clinical definition is shown on this slide. So it would be excessive acquiring and inability to get rid of possessions, a situation where attempts to part with items causes distress and anxiety, where the individual has difficulties making decisions about what to discard, in other words, difficulty sorting, and where excessive clutter disrupts the ability to use living spaces. There's also usual consequent significant impairment in social, occupational, and other areas. So as I've said, the clutter is a symptom of something else really that's going on. So hoarding is having so many possessions, you cannot manage the clutter, and there becomes a risk to safety. Now, hoarding disorder is a brain-based information processing condition which affects an individual over the entire lifespan. It's a physical sign that something's going on, as I've said, and there's other signs. And there are specific diagnosis criteria that need to be assessed by professionals before anyone is given a diagnosis. One of the things that I found interesting when I started looking into this as a set of situations for individuals and communities is the rate of occurrence of hoarding disorder. 2 to 6% of the population have the disorder, with higher rates over the age of 60. Now, that might not sound like a lot, but it actually contributes to situations for a larger number of the population than we might think. And the estimate of numbers would be something like on the Sunshine Coast, where I live, with a total population of 33,000 people, there may be up to 300 households that are impacted. In the Greater Victoria area, the estimate is that there's probably 15,000 households that are affected. So if we're not seeing this disorder happening now, in the future, and as our demographic of aging happens, we will see more. Simply because the number of adults, older adults, is growing in Canada. Just to put this in context with other disorders with which you might be familiar, the mental disorder behind hoarding behaviors is estimated to affect more of the population than other disorders, such as obsessive compulsive disorder, where hoarding disorder occurs at twice that rate, and 4 times the rate of bipolar disorder. It also occurs at 3 times the rate of Alzheimer's disease. So one of the questions that arises is this universal? Does this disorder happen in other places? And there has been some research that says this happens in the same symptoms and the same incident across human cultures, countries, and genders. So it seems to be something that comes with the human condition that occurs somewhat universally. Why does this happen? This has been described as an information processing disorder in the brain. It involves different brain connections and activations. And that's shown, of course, through neuroscience and the quality of imaging that we have these days for what's going on in the brain. This kind of brain may have less ability to pay attention or to maintain focus, may have less decision-making capacity, less ability to sort and categorize, differences in attachment to people or to inanimate objects, and less ability overall to be organized. And brain scans show clear differences with those diagnosed with hoarding disorder from other brains or other disorders. There's influences in this, in that it can come through genetics, through specific brain function, but also stressful life events. All of these are now being studied as contributing to hoarding behaviors. Also, there may well be other accompanying mental health diagnoses. 75% of people diagnosed with hoarding disorder have other mental health diagnoses and disorders present as well. So they sort of cluster. So dealing with this is complex. It's complex for individuals, for families, for community, for professionals, and for teams. And I spoke to a number of teams that work on treatment of hoarding disorder. And they said in their experience with other disorders that this was the most difficult one to work with and took a lot of time and an incredible amount of empathy and patience on the part of everybody in order to make any changes. So, with this, attachment development plays a part. There may be a lack of skills. Socializing deficits are strongly related, as is perfectionism. So, this is deep-seated and a combination of biology, psychology, cognition, and environment. And of course, individual situations and needs of individuals differ within all of this. Symptoms for hoarding disorder appear quite early in someone's life, usually emerging at age 11 to 14. And by the mid-20s, symptoms may start interfering with everyday functioning, but the clutter is still somewhat hidden. 10 years on, individuals may exhibit clinically significant impairment and meet the criteria for a diagnosis of hoarding disorder. And certainly the clutter starts to be noticed at this point. Remembering that clutter is the most noticeable symptom, but people are also likely to have social impairments, relational, and work difficulties. Now, having individual vulnerability then with a brain disorder leads to social risk as well. And there's other vulnerabilities that will exist with this at the same time. So that can lead to not only complexity of doing something about this, but a real risk if people are wanting to age in place. Medication, while that may help with accompanying disorders, is not found to be effective with the hoarding disorder. Hoarding is chronic and it follows a worsening course, usually that can lead to isolation from family, friends, negatively impact health, can lead to eviction and homelessness, create a public health and safety risk, create a dangerous environment for first responders during a fire or medical emergency. And the impact on quality of life can be quite severe. There may be impaired cognitive functioning that can have a significant impact. Individuals may be socially isolated, unable to work, not engaged in meaningful activity, and dissatisfied with their living conditions due to difficulties with clutter and with sanitation. This disorder then reflects the inability to discern how to sort, how to make disposing and discarding decisions, and probably is from an information processing deficit and weaker cognitive organizing capacity. Over time, the consequences of this disorder can include social problems, divorce, distancing from family and friends, increased risks that we've already talked about, and of course, excessive buying and keeping of possessions may create financial stress. So, by its very nature, hoarding has a huge impact beyond the individual who suffers from it. And this is much more than for other mental illnesses. And family members of those who hoard, whether or not they live with the person with the disorder, are affected by both the emotional toll and the physical consequences. And family members themselves may experience stress, depression, grief, or isolation. There's also a potential relationship to abuse. There may be a direct or indirect relationship of hoarding behavior and abuse. Certainly, hoarding is associated with self-neglect. It raises vulnerability and that may raise the risk of abuse. Or it may be that a hoarder's control over the personal space of all who live in the home and the extreme to which hoarders will go in order to defend their valuable possessions may cross the line into abusive behavior. And there's also a relationship been found between trauma, adverse events, interpersonal violence, and changes in relationship, loss, and the onset of hoarding. So hoarding behaviors may be a trauma response or a response to deprivation or emotional neglect. And hoarding behaviors may result from violence somewhere across the lifespan. So we may be seeing the outward result of inner harm, really. Now, needless to say, problems may arise in terms of housing, the ability to age in place, or to maintain tenancy can be issues, and those are often reported from the communities that we work with. And this is particularly critical in areas with existing housing crises, as on the Sunshine Coast. When housing stock is scarce, prices rise, vulnerable people are impacted and for a variety of reasons cannot secure appropriate housing. And if landlords see clutter behavior and other impairments as problematic, and it's a seller's market, then homelessness or being unhoused may occur. So, what are we hoping to have happen in situations where there is a risk to individuals and to family and community? Well, two desired general outcomes, which would be that we have mental and social wellness for as many people as we can, and secondly, that we maintain public safety. So, a holistic approach to this set of situations uses actually two teams of professionals and those related to the situation. One team would be for wellness for the individual, planning therapy, social and life skill interventions and training, and planning the interagency cooperation that's needed to have wraparound care for somebody. Another team could deal with the living and residential setting and the safety, health, and housing aspects. Both require conducting harm reduction activities, that is, reducing the risk by tackling the priorities in the situation. And you probably know that assessment and intervening is elaborate. It takes time, skills, sensitivity, and resources. And we actually do have a fact sheet available to show which case management work for each outcome can happen, which occupations are involved, and tools that can be used. Important to understand, though, in this set of situations is that a family member is the person who most often gets help for the person who may have hoarding disorder. So the role of family is absolutely critical. The individuals themselves likely lack insight about their own behavior or carry a lot of shame or is withdrawn and wants to keep the issue private. And all of those things are natural reactions, but they make then un unpicking the situation and figuring out how to deal with it even more difficult. Family often tries to help in these situations, but nagging, arguing, shouting, or threatening does not result in reduction of the clutter and can damage family relationships. We also know that forced cleanups do not last. Usually within a year of having had a forced clean out in these situations, the clutter is back at the level that it was initially. So learning about the disorder as one that involves a lack in perception, in information processing, and with skills deficits may reduce family frustrations and friction because at least family knows kind of what it's dealing with then. So if you're dealing with this kind of situation, a good step is to educate yourself on this chronic disorder. And there's some very good resources for families available. They're cited on our resource sheet, and they're available through organizations like the um, Obsessive Compulsive Disorder Foundation, which has a whole section on hoarding, which is seen as separate from OCD. But there's a lot of good, useful, practical, and evidence-based solutions, I suppose, offered by that foundation. Talking to family members with non-judgmental language and conversation that encourages change and language that supports without enabling is key. There are some offerings around strengthening families to be able to do that. And the BC Schizophrenia Society has had a course called that, which covers the impact of stigma around hoarding, how to communicate with compassionate interactions, and also has support groups around mental illness. The Canadian Mental Health Association sometimes works as a broker to connect individuals and families with useful resources. And at one point, CMHC on the North Shore has offered groups for families dealing with the issue. Island Health offers a hoarding webpage. It also offers telephone numbers, a support group, a Facebook group, and link to a public safety team. And you'll find that on Island Health's webpage. You can also get information from your primary care provider, and you can talk to them about referrals to the adult mental health team if you have one in your community. A primary care network may be able to help coordinate services because it has a more wraparound approach with access to medical services, counselors, and social workers. Strengthening community members, family members, so that they can continue to advocate on behalf of their family members is a really important piece as well. So in order to get help, these are the steps that are recommended by Dr. David Tolan, who's a specialist in hoarding disorder. And they're both handy for individuals and for agencies to know. So the first step would be to try to get an assessment, and that can be done through adult mental health services through the health authority, and your GP can help. GPs are a gatekeeper often to different kinds of assessments. There is a particular kind of cognitive behavioral therapy, a specialized kind, which is sometimes available through adult mental health, that is cited as one of the few real successful treatments to date. These cognitive behavioral therapies are sometimes available through private counselors, and you can find out who has that specialty by going on websites like the BC Association of Clinical Counselors. There may be support groups that may be for this issue or for other mental illness that are being run by adult mental health agencies through health authorities or other senior support services that are running support groups. There also may be help through professional organizers who have a specialty in dealing with this disorder. Now, that requires fee for service, but can often be very useful in terms of figuring out a strategy to deal with the actual physical manifestation of clutter. It may be useful to speak to your family physician about medication if there are other disorders that are clustering with the hoarding disorder. And there may be medications that are helpful for anxiety or depression that would be part of the picture. There's also some self-help publications, including one called Buried in Treasures, that are easy to read, that are authentically the voice of those who have the disorder, and that really help to understand from the point of view of individuals with a disorder what it is like to be dealing with what they need to be dealing with. So in terms of the individual, we all need to learn non-judgmental ways to interact. Family and friends are the ones who most often help with this issue. Assessment is the first step towards figuring out what's going on and making a plan, because it may not be hoarding disorder that's happening, but before someone plunges into treatment, it's very good to know what they're being treated for is what the need is. And treatment requires a number of coordinated approaches and is long-term. But let's now turn very quickly to public safety. So private vulnerability then becomes a community and public safety issue. There'll be a long-standing relationship to clutter. It accumulates to an unsustainable level, and there's issues that build up. It can be safety, health, social isolation, family issues, community issues, housing, and so on. So daily functioning of the individual are at risk here. Neighborhood relations are often at risk. There may need to be crisis intervention, and housing may be unsafe. Clutter can contribute to falls, fire hazards, or raise the risk of infestations or structural damage. There may be deficits in social interaction, and hoarding often becomes public when neighborhood relations break down outside of around the outside clutter. Extreme clutter situations sometimes come to light through crises when someone has to be removed from their home or returned to their home from hospital. Now, this problem crosses professional scopes of practice, so you need more than one agency to be involved. And just to note that community response networks do not intervene in this, but might be able to broker amongst agencies how it is that they're going to respond, and might be able to help with communal type protocols in your community for how it is that response happens. For there to be a significant coordinated response, each agency needs to show a high and consistent level of response and collaboration. Some will be focused on safety and health, and others on individual health. And these responses need to reinforce each other. So the effective approaches that are being used right now are approaches as in the heat and heart teams. The heat team is the island health response that pulls together fire, environmental health, clinicians, and so on to look at specific situations. And usually these teams have a combined assessment and best practices. And the University of BC has a center on hoarding research that has some what are seen as best practices in North America that they have developed around how to assess as a team and what the best practices are, particularly if there does end up being some forced decluttering. And these teams need to not only collaborate, but to educate themselves and understand at a societal level what's going on with these situations. So health authorities and some cities have specialized numbers, web pages, and teams who offer assessment and support. Situations may require intervention and long-term support. And these providers, shown on the right, are the ones who may get involved, and this requires coordination. And this requires a lot of uh, mutual team understanding, I'd say, and communications amongst professionals must be effective. Now, here's the information on the teams that operate for Vancouver Coastal Health and for Island Health, and also the reference for the knowledge exchange that happens at UBC. Some health authorities, as you can see, have dedicated resources. All health authorities should be able to direct you to their adult mental health departments, although they may not have specialists or may not have responses developed in the same way as the areas that have teams. Now, just a note about how CRNs can help. Members of CRNs may be pulled out to be part of community teams, and CRNs can help incubate that development until they are independent. Because individual members of CRN, such as RCMP or health workers, may work on these cases anyway, but the coordination aspect is what CRNs can offer. We, as CRNs, build protocols routinely about who does what, how, when, and where, and also have fingers out into the community for other resources. So we need a coordinated community level approach. It's hard for everybody to deal with this situation and this condition. We really want to make sure that we have harm reduction and tenancy protection if possible. Practical cleanup and safety requires a person-centered, multi-agency approach, and results are not immediate. So really, we can expect that we might get some harm reduction, both for the individual and for the living condition and spaces. With treatment and support, individuals can be aided themselves in making decisions about decluttering. The key is to work on the priorities in the situation and to keep individuals and the communities they live in safe. So as I said, we have fact sheets, resource guides, and a reference list that's available. We have a rack card that we hand out to the public that talks about both the individual situation and the community response that can happen. And that's been very useful. This is our resource guide, which we're happy to send to you, and we will make part of the package that we send after this presentation. And I'd like at this point to turn to questions.
All right, great. Well, thank you so much for that very informative presentation. I feel like I learned a lot and had no idea that hoarding disorder was an information processing disorder. So that's really helpful in terms of how we think about a disorder like this. I know we already have some questions in the chat in the Q&A box, so I will jump over to them. So our first question is about interior health and if there's a specific team or contact information that you have for that region, or would it just be contacting the older adult mental health there?
Yes, it would be contacting the older adult mental health. I think health authorities are mobilizing as they can around this issue, and we'll probably see, um, I would predict that we will see more multi-agency responses in the future, but certainly talk to either the general number and just ask for adult mental health intake, or on the Interior Health website, there may be specific numbers listed.
All right, thank you. And then there's another question from Anne asking, how can we help if a senior is in an extreme clutter situation but refuses to part with any accumulated possessions while in a larger home? So this is an example of a senior whose home needs organization, and he's opposed to getting rid of everything, and he's not able to afford to pay for any organizing services, and at home, they can only pay for a deep clean. So if you have any suggestions for how you might be able to approach that type of situation.
I think that that is a typical situation that's really difficult. Um, I would say approaching it, if there are home and community care social workers, might be one way to do that. Um, as a matter of fact, contacting whoever the local health authority, home and community care uh, department is, they may they will have dealt with these issues before. They just may not have an official team to do that. But I would say talking to a social worker is a very good start.
Yeah, great, thank you. And then we have another question about the mental health assessments, and it's, can I confirm with you that we need the hoarder's consent to get a mental health assessment? So you talked about that as being one of the steps in terms
Mhm.
of the pathway. And I think from the community agency perspective, they want to know how they would go about involving mental health and getting that assessment.
Um, I, yeah, I don't believe that anybody would do anything without the consent of the person involved. And usually, having family advocates, family or friends advocates, to provide support around that, and to maybe involve the person's GP. I mean, finding trusted relationships where they exist, and then leveraging them to give support for doing these kind of steps is probably the best way in. And that means that people need to be skilled in the conversations around difficult issues, and also have the understanding of why these situations are so difficult, and the understanding that the person that they're working with has a different way of perceiving and of taking in information. But family members who know other family members and care about them a lot are probably the one of the keys here.
Yeah, thank you. And then I think there's been a lot of comments in the chat and other places just requesting the resources. So I just want to confirm to everyone, we'll be able to share out those different resources that April has shared. All right, and so we have another question about what about pets and animals that are living in extreme hoarding situations that are not safe or of concern? Is there a duty to report, and how does that work with confidentiality, and who are we reporting to?
Hmm. I do know that in terms of animals, and that is a kind of a specialized piece of the picture that may exist, that BC SPCA is has some knowledge about how to manage those situations. They are usually brought in as one of the team members if there's an interagency approach to a situation. And I mean, really the key is getting a multi-agency team looking at the situation so that each of the team members can take on the parts that they are specialists in. An outsider trying to sort out what's going on is probably not going to happen. Um, and really, it's also best not to get over involved in situations, but to hand it off to professionals if you can, just because of the complexity and the sensitivities, all of the above.
Thank you. And there's a few more questions, so we'll see if we can get a couple more in before we
Yes.
close. Um, so one is noting that you've clearly identified that the solutions and help come from a collective effort and a unified approach. And the person has a question about what you may think is the best option when a client or participant does not think they have a hoarding issue. And they note that the HEAT team provides info to help those who want to be helped. But in my experience, they've been unable to help our better at home clients who I guess don't want help. How do we realistically help these people in a timely fashion while maintaining sensitivity when it comes to urgent tenancy and safety issues?
Well, when there's urgent and critical issues happening, things will be taken out of the hands of the individual sooner or later, just because of safety concerns in one way or another, probably. Um, Trying to maintain a relationship with somebody when there may be limited insight. That's one of the things that clinicians have mentioned to me about the hoarding disorder is that there will be probably lower awareness of the fact that this is a problem. Um, so maintaining a relationship of any kind with the person is better than none. And continuing the non-judgmental um, language and using the motivational interviewing techniques and things, conversational techniques that are evolved to help enable change. That's about the best that you can do in those situations. Um, it's always good to reach out to other professionals, whether or not you have um, a heat team or a heart team in your area, and certainly our CRNs, because we already work with a number of um, uh, service agencies around abuse issues. We would always reach out to them first. And it may well be there can be ad hoc uh, multi-agency things happen, even if they're not official and not necessarily supported uh, by, across the board by major organizations. But this is a situation where things need to de-silo. And of course, that is what causes a lot of the response problems is the fact that we live in a siloed set of organizations. So, um, but again, maintaining relationships wherever possible, expecting if there's ever changes that they will be tiny and slow, and uh, being as respectful as you can. If you think that there is something critical going on, like abuse, because of course people are vulnerable in this situation, right? Then report it as potential abuse to designated agencies, which are the health agencies. And there will likely be a phone number on health agency websites for how to do that, or you can contact us. As a matter of fact, we'll include the information about what the um, best phone numbers are for each health authority to get designated responders to have a look at situations.
Yeah, thank you very much, April. And there's two last questions. Do you have time for them?
Yes.
Okay, yeah, we'll take these two last questions and then we'll wrap up. So, one question was just noting that a lot of people that they work with don't have any family and friends in their life. And so then what would be the most helpful way to approach in that scenario?
Well, again, I mean, if you have a reason to be in their lives, then maintaining a relationship that of the sort I've just described, in terms of the conversations, um, is the best that you can do, likely. If you think things are deteriorating or getting worse, though, always call one of the formal organizations that we report to around crisis. And they may be able to leverage something different that you are not able to in your role.
Thank you. And then the last question is just somebody's asking about how do you approach a senior who's trying to declutter by selling items which aren't selling and that holds up getting rid of things.
Well, I think those conversations, bringing up this as uh, I notice there's a problem in our plan here in that we thought we could get rid of stuff by selling it. That's not happening. What's what's our backup plan here? Well, and continue to suggest different solutions because the person themselves may not be able to generate solutions or see farther down the path. Again, there may be cognition or uh, different perceptual things that stand in the way of that. So supporting with good, gentle planning and always saying, well, we're not going to stop, but let's try plan B, C, D, Z. Might be quite a long planning pass.
Great, thank you. I think from the questions that we've heard today, and then also the information and insights that you've provided from your presentation, we can all see how complex all of these situations often are with hoarding disorder. And so I think you being able to shine a bit more of light and provide some more information about the disorder and then also the resources that are available has been really valuable. And I know our participants are eager to get their hands on those resources. So we will, of course, as I mentioned, be sending out the recording and then also the additional resources in a follow-up email. So please look for those if you want more information. And then also, as April, of course, has mentioned, there's different parts of the healthcare system like specialized hoarding teams, or if those don't exist, older adult mental health and social workers, home and community care, who also can be approached and can support in these situations. So hopefully everyone has taken away some useful information from this webinar. And I really appreciate your time, April, for the webinar and also for staying for a few more minutes so we could get to all the questions.
Thank you, Laura, and I really appreciate all the questions, all the interest and the care that is being shown in people's responses to this presentation. And who knows, as we learn more and as we go forward, we may have part two, and we'll keep you informed as to what that might involve. So thank you for the opportunity to do this.
Yeah, thank you very much. And I hope everyone had a good time at the webinar and has a lovely day. Take care, everyone.